without getting too detailed, it's unnecessary really, is just, look, these are naturally occurring molecules in our body that signal our body to do different things depending on that sequence or that computer code for our own body.
Would you say it's kind of the same thing here? Like the toxic exposure is probably also contributing to the decrease in our peptide levels?
Yeah, because, this is all signaling pathways. The reality is the signaling is being disrupted.
What is the difference between, to you, a peptide versus a drug, a pharmacological agent, right? What is the difference? How do you differentiate the two?
A lot of things can be considered a drug because I like to look at what is a naturally occurring versus what is, a chemical that we've used. Because what's normal to our body? I should say that.
Why is it that we're seeing so many amazing things about this particular class of drug compared to so many other drugs before?
It's helping people.
Welcome back, Doc. How's it going?
Great. Having a wonderful day. How are you doing
good,
today?
Man. I'm doing good. And, I want to dive right in. There's so much excitement right now about peptides. Peptides. And rightfully so. We've used them a lot. I know you have a ton of experience with them. Yeah, there's so many questions I have for you that I want to dive into. Why don't we just start with sort of an intro? What does peptide therapy mean?
So I think, you did a video on peptides. You do a really good breakdown. Peptides they're naturally occurring molecules in our body, and they're just a sequence of amino acids. They're just not as long as a protein. So people hear about proteins, they hear about amino acids. It's just an arrangement of amino acids, and I think about them as computer code. And it's like, okay, this particular arrangement of amino acids tells the body to do this, and the one peptide most people are familiar with before, Ozempic and semaglutide and these GLP-1s is insulin. Right. Is a peptide. It's a signaling molecule. And I think, without getting too detailed, it's unnecessary really, is just, look, these are naturally occurring molecules in our body that signal our body to do different things depending on that sequence or that computer code for our own body. I think computer code is a really good idea to think about how a peptide works.
Yeah,
right?
I haven't heard anybody call it computer code. Signaling agent, right, would be the kind of the thing. Signaling agent, but computer code. The purpose is to communicate something else, another target tissue or area to do something specifically, right?
Right. Yeah, absolutely. So they're there's and because of that, every day, I know you and I have talked about this, but there's so many more peptides being discovered now and what they do, and then understanding, the full scope of what a single peptide is capable of, and just with like semaglutide, these GLP-1s, what they're seeing it does for the heart and the brain and all these other systems in the body. So, but when we're talking about peptide therapy, it's, you're choosing a particular peptide to have a very particular effect on the body, either, to create something the body hasn't been doing or to amplify a response that the body has been doing. But a lot of times, it was really interesting when someone had asked me the other day, why do I need these? And one, most people are deficient. Our total peptide concentrations do tend, just like growth hormone, they tend to drop as we age. The more exposure to things we have causes them to drop. But you have to have good amino acids. You have to have good absorption. Your gut's got to be working. Your diet's got to be dialed in. And a lot of the places like, the normal space that we're going to see some of these produce, like the semaglutide, is a gut. It's a healthy gut, and the body's not producing it like it once was. And so, I think, and as years go by, we'll probably find that some people genetically, they have variants that make them not produce these things, or without them being in a particular concentration, their receptors aren't as strong for certain peptides. So we're on the front edge of something amazing,
right? Would you say like testosterone specifically, we know the biggest driver is, our endocrine systems, which is the production of hormones. is just getting derailed by so much toxic crap. I mean, the list just seems to be growing. Would you say it's kind of the same thing here? Like the toxic exposure is probably also contributing to the decrease in our peptide levels?
Yeah, because this is all signaling pathways. The reality is the signaling is being disrupted. I often think about it like, you remember old TVs? If you didn't have the antenna right, there was a bunch of static on the screen. It's our bodies are full of static now, from chemicals, from our micronutrients being disrupted, our stress is off, our sleep cycles are off. So all these different like influences are or disruptions, they're basically like creating static in our bodies that are interfering with the proper
Yeah,
signaling.
yeah, no, that makes a lot of sense. How would you compare and contrast a peptide and a hormone, right? Because they're very similar, right?
Um, yeah. One, peptides can be a little bit more
Yeah.
general, right? I mean, growth hormone has a lot of particular tissues that it hits, but peptides seem to be a little bit more universal, right?
In,
So
in
they're
terms of what
gonna
areas
they
they can target, tissues they can target. Okay.
yeah. Yeah, and the more, research that comes out, the more we find like they have bigger ramifications. But they're not just released or stimulated by our endocrine system, right? So these are coming from what we used to consider non-hormonal tissues, right? So peptides are coming from a lot of different tissue sources. But it was funny, one of the pharmacists for a compounding pharmacy, he was saying, well, almost every tissue releases something. But I just think about it in terms of what their specific pathways are. And peptides aren't always going to, induce, tissue growth. Sometimes it's just a certain behavior. And so I think hormones are going to be a little bit more tissue specific, and we actually can narrow those down, whereas the peptides seem to be a little bit more
Is there
universal.
anything that you've seen or what's your guess as to also another potential difference would be the timing, right? Because peptides degrade so fast, yet it's like they can turn on a process that can last a really long time in some cases, even though the peptide degrades. But then hormones seem to float around like when they're produced for a lot longer, right? Continuing to sort of activate.
Yeah, I think the half life on a hormone can be massively bigger than and longer than when we see these peptides. That's why, like if you're doing, someone's on testosterone therapy, you're not doing near the
Right.
frequency than you would with a peptide. But structurally, that's a big difference. Hormones are typically much longer amino chains, and I think really talking about the different classifications, what they do, the tissues that they target, their half life is a lot
Yeah.
different, right? So, and I think you can with the synthesis, how these things are made and where they're stored is quite a bit different when we're talking about the different peptides and the hormones, because you're going to get hormones from very particular
Right,
tissues.
right. Yeah. No, that makes a lot of sense. I get asked that question a lot, and I find myself just as a quick way to describe to patients, because peptide's so new, right? People have heard of hormones, right? They have more familiarity with it. So I just tell them, think of it like a hormone, the way a hormone is released and it causes a signal. And, too much of a hormone could be a problem, too little. And, thinking of for a quick reference, I'll mention that. But yeah, no, that's definitely fascinating for sure. And this whole thing is just, watching it evolve and change over the past few years has been amazing. And quoting Dr. Huberman, he mentioned this is such a unique situation for us to be in front of this therapy that has actually very little human data, but
Yeah,
a ton of animal data, very little human, yet just an insane amount of anecdotal evidence, and
it's
everybody's
crazy.
saying, hey, I'm using it, it works. Where are the side effects? Where are people reporting adverse events? Like, have you seen any? I haven't seen any adverse events.
I've only seen site
Right.
injection, response. Like some people would get like a hive or a whelp
Yep.
on only particular ones, like CJC. We've seen that, you know, pretty frequently there. But the outside, I think when we're talking about peptides, the negative outcomes, we have yet to see any, other than someone having like an allergic response, and that's a one-off. I've never seen a negative outcome. And even some of this stuff where they're saying, okay, well, it can create some abnormal growth. We haven't seen anything like that. Plus, you do your due diligence, but that's only on your growth hormone secretagogues. But we're not like BPC and the any of the GLP-1, the GIP agonists. Those are amazing. Epitalin's been used in cancer trials, so it's crazy the amount of preliminary data that's out there, right? But there's really good safety studies on some of these. So, man, I think years ago a friend of mine said amino acids and peptides are going to be the medicine of the future, and that was in 2009. And here we are. But bodybuilders have been using amino acids and then peptides longer than anybody else. And if those are good, that they're doing only what's going to work. They don't do stuff that's not going to work. And they may push the limit, but that's what they're doing is they're pushing their body to a physiological limit. Some good, some bad, but there's a lot of evidence there that these things have a real role in human optimization.
Yeah. No, I mean, it's a damn shame what the FDA is doing. And, the FDA does what they do, and I always, tread lightly when I discuss this topic. They are looking out for the safety. And, technically speaking, we don't have enough human data. So when I make the observation and statement of observation and you two not seeing adverse events, that's all we can say is that, right? And, at the same time, they can say, well, we need the safety data. What I've heard talking to many compounding pharmacists, rumblings that we're going to see CJC 1295, ipamorelin, and we're going to see BPC get FDA approved. Yep. And so This is why, the recent move to remove them off the market has happened, because that's in motion now. So that's crazy.
Yeah. Well, and that tells you if they're moving them into a drug, that means they work.
100%. Right? 100%. So it does suck for everybody in the meantime that's now struggling to have access to it. I mean, that's the part that, and there's clinics like us that are still going to, provide what we can within the range that we legally can do and help people to the best of our ability. Cause right. that's what we do, but, okay. So, man, there's so many directions we can go. GLP-1s, we should probably start there because I got this question that's been burning for a while. And maybe you know the answer, maybe you don't. But I always resort to you for the really in-depth stuff. But this isn't too in-depth, I think. So, okay. Before I even get to my question, let me start with the preliminary question. What is the difference between a peptide versus a drug, a pharmacological agent, right? What is the difference? How do you differentiate the two?
There are a lot of things that are considered to be a drug based on their mechanism. Where I draw the line, I'm going to say this based on feelings and view on this, is that typically a lot of things can be considered a drug because they have this systemic effect on the body. I like to look at what is a naturally occurring versus what is, a chemical that we've used. Because what's normal to our body? I should say that, because you could take something that we know works really well. We know that like aspirin, you can find like willow bark extract, white willow bark extract has like an aspirin type NSAID that's naturally occurring, but it's not natural in our body. We have our own pain endorphins and these neuroopiates that our body produces. But most of these peptides, the peptides that we use, are naturally occurring molecules in our body. Now, there are some growth hormone secretagogues that, mimic a response, but a lot of the peptides they're normally occurring molecules that can be found in our body. They're not like a foreign thing that's creating a massive systemic signal that's disrupting function. And I really I get really cautious of things that we know for sure are either, suppressing a pathway. A lot of times when we're looking at health in general, most of the things we do, we're upregulating normal function. We're very rarely suppressing things like forcing blood pressure down, suppressing clotting factors, suppressing the immune system. Most of the things we're doing, like these peptides, they're amplifying and improving normal functions that already occur. But my gosh, we could probably write a multi-page thesis just on theory alone, outside of any of the pharmacological effects of drug
Oh,
versus
I know,
peptide.
and I knew you would have a response like this, which is amazing. So, uh, what I have been just find myself, and this is a working, like you said, my theory, right? Because I don't think we have it defined yet in science, but to me, very similar to what you were saying near the end is, you know, a peptide is a naturally occurring agent, and a drug is foreign. And I think to me that seems to be like the end all be all summary. And listening to you, is it fair to say that that's the summary of what your position is? If you had to differentiate them, or is there a little bit more to it?
Yeah, I think, yeah, I'd say, a drug is something that's introduced to our body that's not normal to our body, that disrupts
Right.
normal function.
Right. So just for shits and giggles here, I went to Perplexity, which is my favorite AI tool. I just want to read to you this paragraph in summary, right? All I asked AI was the
Okay.
basic question: what is the difference between a peptide and a drug? And for listeners out there, AI is going to be a much more in-depth search than Google. This is actually going to digest the question in complexity and spit off information from various sources, and I can actually ask it a second time. Actually, let me do that now. I'm going to ask it to search it, and we're going to compare the answer here really quickly, because I think this is fascinating. I even like the answer right now it gave me, but now I'm going to use the second. The reason why I like Perplexity compared to ChatGPT is I can tell it on the next search to only look at research, only look at YouTube. I can narrow down its database of where it's searching from, which is really nice. But just this first
Yeah.
answer, I think, is fascinating. So, in summary, peptides are small molecule drugs, which notice how they use drugs in the definition, right? Which is interesting. Differ significantly in their structure, function, and therapeutic applications. Peptides offer high specificity and mimic natural biological processes, but face challenges in stability and delivery. Small molecule drugs, on the other hand, are versatile, cost effective, and easy to administer, but they have a broader effect, higher toxicity. I love that this is completely like coming to us like right off the gate. And usually these answers, they're scrubbed and biased in favor of allopathic stuff in some cases. But both classes of therapeutics have their own unique advantages and are chosen based on specific needs and treatment regimen. Now, out of curiosity, let's see the summary answer based off of just data and not Google search results. Peptides and drugs can overlap in their therapeutic usages. They differ significantly in their composition, specifically administration routes and regulatory considerations. Peptides offer high specificity and biocompatibility, but face challenges in stability and delivery, whereas drugs provide a broader range of applications, administration methods, but may have more side effects and regulatory hurdles. Interesting. Interesting, right?
Yeah.
So where I'm going with this is, because I haven't even got to the point of that question, because so it sounds like we're on the same page, right? Naturally occurring versus foreign. So now let's get into the fact that some drugs that are made are actually peptides. And this is where I'm going with this, because it gets really confusing. Are GLP-1s, and now we're talking about Wegovy, Ozempic, Mounjaro, Zepbound, right? Active ingredient semaglutide or Zepatide. Are they a drug, or are they a peptide? Because people use both words. And if we talk about BPC 157, that's a naturally occurring peptide. It's made by pharmacies, and it's the same thing as the one in your body. Yes, it's synthetically made, but it's synthetically made to match what's in our body. But now we're talking about these peptides that are severely altered, right? But they were altered from a naturally occurring agent. So that's why I get really like, what do we call them?
Yeah. Well, man, I think the lines become convoluted, even when we're talking about hormones could be considered a peptide,
right?
right?
I see those
So,
interchangeably
okay,
used
what's
a
the
lot
difference?
as
Yeah,
well. Yeah.
yeah, yeah. I've actually seen hormones like referred to as a hormone peptide. I think the overlap is going to be really strong. I think what we're doing in this day and age is we're classifying very particular things due to their amino acid structure, how long is just saying, okay, anything under this amount is a peptide. I remember when they started coming down on cerebrolysin and thymosin alpha 1, it was like they actually, the FDA came in and said it's too many amino acids long. I think they took it down to 40, right? It's just like, okay, anything 40 and bigger is considered a
Right.
drug. And I don't know, why that cutoff at 40 changed its, you know, bioregulatory effect, or, why that all of a sudden that
It's
was the
biological. They call it
cutoff,
a
right?
biological agent when it's above 40, right?
Yeah.
So yeah, I wondered that too. Actually, I don't know.
Yeah. I think in general, you could, drugs can be natural or synthetic. And it's just things that, that interact with our body. They're all signaling molecules and tell us different things. It's going to really come down to how we're classifying those based on how we're using those. But I really, the thing that you brought up on that definition was the
Right.
toxicity. That is that
Because
is definitely something to
yeah, because
consider.
look, you can inject a shit ton of BPC, and you're not gonna hit a toxic load.
Yeah,
In fact, I think I remember saying they did 1 gram per kilogram of body weight. 1 gram. Remember, the clinical dose is micrograms, not even
yeah,
milligrams, and it
yeah,
took that much to actually hit a lethal dose. So, and these are rodents. So, that's I mean, that's thousands and thousands above what the clinical dose is. So then you look at drugs, and now we're talking the threshold to toxicity is significantly lower. And isn't that the
yeah,
definition of a poison, right? Like how we define
yeah,
toxic and poison, toxins and poisons is how small the margin of the lethal dose is, and that's considered. So
yeah.
you apply that same concept, and we're just speculating, we're just spitballing here.
It was the LD50, right? The lethal dose 50. I've never seen an LD50 for a peptide.
Oh no! I mean, the most thing the thing that happens if somebody accidentally, and I've seen patients like, oh my god, I injected 10 times, 100 times, they might get a little nauseous. That's the worst I've seen. Some nausea.
Yeah.
I wanted to interrupt for a quick minute. I have a free peptide guide. So everything you're learning today, we put it down, the protocols and exactly what you need to know. You can access that by clicking the link at the beginning of my description of the video. Now back to the show.
Yeah. We had someone that was taking PT 141
That's the big nauseous
formaldehyde.
causing one. So video do that one.
Yeah. Yeah. And the dose is like point 0.2. They misread and did 2.
So 10x.
And yeah, so they 10x'd it. We're talking like an 8-hour erection, but you know, that's and one could be argued. I mean, he had to be monitored, but it wasn't going
Right.
to kill him.
Right. Probably had a
So
couple points of BP up, and probably that's
yeah, yeah,
hilarious. Oh my
yeah,
gosh. Yeah, so I think the lethal dose, the toxic dose, I think that definitely needs to be part of this discussion as far as establishing the difference. And again, where I'm
yeah,
going with these questions, because I want to lateral hill here over to GLP-1s, but why is it that and this is sort of a big question, not a specific question, but why is it that we're seeing so many amazing things about this particular class of drug compared to so many other drugs before? And I'm not saying there's no free lunch, and I'm not saying there's no side effect or risk. There are with these medications, like all, but there's a big difference that I'm seeing between this class and many other classes. Like for example, diabetic medications and cholesterol medications. These medications basically get the job done to handle the acute problem and come at a cost of
yeah.
many other problems. But the
Right,
GLPs,
right.
they do that same thing, but now we're seeing an insane broad spectrum of improvement among so many other parts of the body. And we never saw that. At least, I'm not an expert in medications, but to my experience and knowledge, we haven't seen another class of meds where we have such far sweeping improvements. I mean, these medications, these GLPs, are being studied for Alzheimer's, neurodegenerative diseases, addiction issues, non-alcoholic fatty liver disease, chronic kidney disease. I mean, there's so many applications that the future looks like it's going to be kind of wild, right? Like what's going to happen.
Yeah.
And we haven't seen that with other drugs. And so I'm sitting here just trying to speculate and go, okay, well, going back to the definition, because now it all relates, like these other drugs were completely foreign, right? I don't know the process of how they started the production of those and to get the job done, but I'm just imagining it's completely foreign. But then you look at this GLP medication. I'm calling it a medication because it's foreign still, but
Yeah.
the base of it, the incretin hormones, right, were naturally. And so now you can almost say, this is just my opinion, that this is a modified version of a peptide. And so it's in this quasi category. So maybe that's why the side effects are lower and more tolerated. The benefit is better because it's not a completely unnatural foreign substance. I don't know. What's your take on that?
No, I think that's a great explanation. And I think, when we're looking, if we looked at the root here, these medications hit upon one of the major root issues. So if someone has some insulin resistance, and we know people develop insulin resistance way before their A1C goes up, because what their body's doing is the more glucose is hanging around, the higher the insulin goes. It keeps going and going and going and going into a point to where finally the cells have been oversaturated with insulin signaling. And so what is this medication doing? It's improving that insulin signal. It's, I know like the tirzepatide and retatrutide, they also minimize the glucagon, signaling. So we're not freeing those things up. But it's helping people not overconsume calories by slowing that gastric emptying process. And so you're hitting a really key point that's never been addressed before. It is a natural molecule. And so you're changing and you're giving people benefit. I think, years ago, studying all the diabetic pathways, when someone develops insulin resistance, a lot of times people don't get the correct knowledge on what that means for them. And the food's been engineered in a way that you eat it, you crave it. I mean, eat just one Dorito. I mean, there used to be a commercial. It's like, you can't eat just one. It's like, yeah, because chemically, you're acting upon all these pathways in our brain that tells us we need that. It's like this mass consumption was there, but also when people do develop insulin resistance, think about a nerve, for instance, the nerve will start to die, one, because there's too much glucose, but two, it's starving. When you have too much insulin resistance, even though you have all this energy, it cannot be used, so the tissue starves. That makes you ache. That makes you have cravings. Your brain is saying you have to eat. This GLP class slows down the gastric emptying. It calms down that insatiable appetite that's there. It's keep people from overeating, and it's improving these insulin pathways while not allowing massive amounts of dumping of glucose back into the bloodstream. So I think, and the fact that it's something our body naturally has, so you're just amplifying that signal that has been massively turned down, and we're making use of an ancient pathway that's been in our body forever.
Yeah, that was beautifully said. Yeah, I mean the alterations they're doing to it has really just been, from my understanding, just a manipulation of the half-life. That's literally what it is.
Yeah.
And don't get me wrong, I mean they significantly alter the half-life, and yeah, I mean we're talking the
Yeah.
original molecule lasts in your body for like under a minute or two, and that's it, and it's gone. And then they got hours, and then they got more hours, and then they got to a day, and even the huge advancement with like Trulicity. And then finally, when semaglutide blew up, that's when things became really magical. Number one, because daily injections are tough for a lot of people, and then number two, the results from having that stimulation for 7 days, and then tirzepatide, hitting more
Yeah.
receptors, and then like you mentioned retatrutide. So the future is fascinating. But yeah, just to kind of play on what you were saying, sort of in discussion of why they're so amazing and potentially so different than any other drug. And I bring this up because both of us are so functionally rooted and holistically rooted, but I'm like, I get sort of pushing drugs. And I'm like, no. I'm trying to. I'm using them, and a lot of functional practitioners don't want to use them. Like, stay away. But that's just because I embrace the concept of like, we need help. We got the same goal. You're not willing to embrace the medications I am. Like, okay, fine, but we got the same goal here. We're trying to get off as many drugs as possible. So when I think of these medications, right, in summary of what you were saying, they decrease insulin resistance, like immediately, which we've never had a drug do that, to just make you instantly more insulin sensitive. And they decrease food chatter, decrease food hunger, right? Hunger. So, by the way, which is the combo of both is beautifully producing weight loss, because those are the two biggest things. But again, going back to other drugs, right? Cholesterol, blood pressure, blood sugar. These are all very symptomatic things that are just byproducts of something underlying. So this is, to me,
Right.
This is the first class of drug that we have that's getting, some people say it's getting to the root cause. I do this podcast with Dr. Eberwein, and he's just been doing GLPs for 20 years. He's a medical doctor. He believes this gets to the root cause, and I totally see where he's coming from. I look at it as getting to the closest to the root cause we possibly have ever been, pharmacologically speaking, because directly making you more insulin sensitive. But then I think this is where the functional comes in. I go, well, technically the root cause is the lifestyle, right? And so that kind of crosses. Yeah. So he is right pharmacologically speaking, but if we just look at the big picture of just root cause in general, it's lifestyle, right? Lifestyle. So
yeah,
again, why are they so amazing? Why do they have such broad sweeping effects? I think it's because we got to the closest we've ever had to getting to this root cause, which is amazing.
Yeah, I think you're altering behavior, and that's so powerful. And also, metformin does a job. It's just not a thorough job, and there's side effects of metformin. But metformin, it's been found to increase lifespan. And one of the things that this shares these GLPs with metformin is it doesn't raise insulin. You're not adding more insulin. You're improving using insulin. And I think that's a huge piece, and we're not inhibiting any major pathways. There's something to be said about slowing down motility, but my gosh, the ramifications that we're seeing from these things, like the Alzheimer's studies, that preliminary data is
I think it's not a coincidence why metformin and GLP-1s in their own class of diabetic medications and actually promote weight loss. When you look at so many other diabetic medications, they promote weight gain, right? Looking at the effects of insulin. And then obviously, if you get to a point where you're injecting insulin, that's when you have the most weight gain. But yeah, I think 100% agreement. I think metformin is amazing, but it's kind of almost like obsolete now when you have GLPs.
Yeah, well, when it's crazy to think about, when you talk about I think this is the closest thing that we've ever had to almost like a magic pill. And the reason I say that is because if Dr. Peter Attia in his book Outlive, he talks about the 4 horsemen. Cerebral and cardiovascular disease, cancer, neurodegeneration, and metabolic syndrome. Because he says very clearly, and we know this, for anybody that metabolic syndrome is this insulin resistance, excess blood sugar. Metabolic syndrome is the one that threads the others together. And these GLP medications, these peptides, they help all 4 because of that. Talk about something that everybody should not be ignoring this conversation. My gosh, right? I'm not saying it's for everybody, but what I am saying is everybody should be paying attention and cued into the conversation.
The crazy thing is, and I always tread these topics lightly and then I move on, but if doctors actually had the green light to prescribe these at the first onset of insulin resistance, it would put major pharmaceutical companies out of business. Done. cholesterol, diet. I
Yeah.
mean, so many. Now, those pharmaceutical companies would grow and be the big, obviously the controlling factors. And so I would imagine there's going to be an insane amount of resistance. And this is going to be really interesting to see. Now we're going to have competition between we've always had competition between them, but now competition on a whole new level because major pharmaceutical companies are going to be afraid of going out of business. At the end of the day, the government's supposed to do what matters, what's best for us. And I think they try. I think they do. I think they try, but it's, yada, yada, yada. I, again, have to tread lightly with the influence, but money is influence. And we're just going to leave it at that. And so what the hell's going to happen in that situation, even for the government being in between that?
Yeah. No, it's crazy. And that's, you've been such a great voice and resource for people. And I love, your content, because you're doing it responsibly too. Because like we're saying, we're not saying don't blindly go out there, do the things that are going to preserve your lean muscle mass. There's a way to come off of these things and maintain that weight loss. And you've been a huge champion of that. And I think that's so important to realize, like, okay, they have their place. They don't have to be permanent. And there's a right way to do it, like everything
100%,
else.
100%.
Right?
So let's lateral into a little bit of that, and then we'll finish off and probably have plenty more peptide podcasts to come. So this is great. Since we've been talking about GLP-1s, so what is your experience with using them? How do you approach using them with patients? I know you have medical providers that do the prescriptions for your clinic.
Yeah, same as you. We have medical staff that work with patients. So one, we have the conversation. Are you comfortable, doing injections with yourself? But it's really about what fits with their health goals, and when we do the labs, what correlates with it, other than some of these GLP-1s, the any of the thing that improves insulin sensitivity. The others we don't typically use as a standalone feature, right? They work really well by themselves, as long as you're doing it ethically and responsibly. But some of the other peptides, they're a really good add-on, right? I think they're amazing. I think they help people leapfrog forward with their health and their recovery of a lot of these conditions. There's only a few that we would use standalone because, again, when you're talking about root cause, diet and lifestyle and exposure, you can't peptide or chemical yourself away from those things. Semaglutide and these GLP-1s, we talked about those changing behavior. Not all the others do that. And so we say, okay, this is first. Lifestyle medicine first. The peptides come in there as an add-on to amplify or have very, very targeted approach to specific things that are going on. We do like to use those, with really difficult autoimmune cases. We've used peptides to help us with infertility cases. So, man, they have their place, and I'm super excited as to where we're going. But how we choose is based on, what a person's labs look like, their genetics, and then also what their health history and chief complaints are.
That's a very thorough approach for sure. When you guys are working with a patient that's you're looking to improve their health, weight loss is part of it. You got them on tirzepatide, for example. What else sort of are you really focusing on, in addition to it, obviously?
Yeah. So in a lot of ours, we don't get too many people that are coming in just for weight loss. We get the people that it's really severe cases of either diabetes or their thyroid's been disrupted and they gained additional weight and their metabolism was wrecked. So it's one, we've talked about with, if we're talking about the GLPs, we're looking at their electrolyte status, that their how much protein they're consuming, what their total caloric intake has been. We do like to have an idea of what their bone metabolism's looking like. Make sure we want to lose weight, but not at the expense of bone and muscle. We've seen good successes with people that have had some very early stage of what looks like neurodegeneration, some early symptoms. So we're focused a little bit more on neurological function and mitochondria in those areas. But, using combinations like hormone replacement therapy and BPC with these cases has been amazing.
It's such a gate opener, right? These GLP ones, like you said, the change in the behavior. So, like I'm looking at them, like you said, right? The lifestyle is everything at the base. Talk to me about, and I'll share my input and tell me what you think. But when I look at this, there's the body, right, that we're dealing with, and then there's the person running the body. Like we're dealing with both, and the person running the body is dealing with the body too, the limitations of the body, right? And so the medication, this is just how I see, gets in there, and this is the physiological, like, right? It gets in there and really handles that part, opens the door, right, for the individuals. Now we're talking about the individual, not the body, that did want to lose weight, that did try to eat better, but kept getting pushed back by the body. Now they can go out and flourish and they can succeed. But the people out there that don't really have that intrinsic initial desire, or maybe they just haven't been educated, they have no clue. Right? The doctor just want to lose some weight, here you go.
Right.
It sucks when that's the issue, right? They haven't really been, or maybe, because I would say everyone's naturally going to be only going to work as hard as they've been told they need to, right? So maybe they go, yeah, I got to try, but they haven't really been, they don't have that coaching environment, that the support, the community to really understand and really get it. And so they're taking these medications, but because intrinsically and that barrier is removed. So, okay, great. I'm doing better. I'm not eating as much junk food, but I don't have that initial intrinsic desire or understand that I got to make these changes for lasting weight loss. And so I think it's so important to include some of that mindset, that mindset component to it through the education and the motivation.
No, I 100% agree with everything you just said. The educating people, raising their awareness, because a lot of people don't know. I mean, when we start talking about these things when we're setting with patients, I know you've had this experience too. People say, I wish someone would have taught me this. When I was a teenager or a child, or when I first started college. What is me? Even when you're talking to diabetics, most diabetics don't really understand what A1C is. And there's this amazing study I'll share with you. It's a study from Israel. It was a 40-year follow-up study. And they looked at A1C starting at pre-diabetes at 5.7 and going up to diabetes at 6.5. And they found that on average, when they did this study, if your A1C crossed over into pre-diabetes, you could immediately take 4.3 years off your life. If you hit and going all the way up to the diabetic range was 14.2 years. So starting at 5.7, subtract 4.3 years off your life. And for every 0.1 you go up after that, take an additional 2 years off your life, 2.1 years. That's crazy. If somebody would have told a diabetic or a pre-diabetic, like, hey, by the way, for every 0.1 this is going up, you're eliminating 2 years right off of your life statistically. And if the average lifespan's 78 for a man, like 80, 81, 82 for a woman, just start counting back and you can immediately, almost know how long you're going to live based on numbers of statistics. That's crazy. But so I think the education on this is so unfathomably important and overlooked, right?
Yeah,
so crazy.
It's that's wild. That's wild for sure. Oh my gosh. I think I would say that's probably a good place to end for today. And definitely excited to get into some more. Probably we'll get into some peptide categories. And then I'd love to hear you just kind of on a general, whether it's this one or that one or the next one, but sort of a general, here's my pillars, my totem poles, my categories of optimal health. Because for me, it's the nutrition, the fasting, the weightlifting, the supplements, the stress and sleep. And I know yours are very similar, but I know there's probably some differences too. So I'd love to get in that too as well. So definitely looking forward to more episodes with you, Doc.
Absolutely. Me as well. I appreciate you having me. It's always an incredible time, and I love the discussion.
Awesome. Awesome.
If you guys found that informative, then you're not going to want to miss this next video. I'm going to link to it right here, guys. Click that. It's going to be a continued explanation of what you guys learned today. We'll see you later.